It's really a great pleasure to welcome Dr. Sean Wharton. I had a chance to be with him on some of the podium regarding the latest in cardiovascular evidence-based therapies, and he's just a fantastic speaker. And so he actually is doctorate in pharmacy and medicine at the University of Toronto, and he has actually spent a little time in Ottawa previously. What a great honor. And so he's a medical director of the Wharton Medical Clinic. His community-based internal medicine, weight management, diabetes clinic is super successful, super well-known, and it's really fantastic in terms of the work he's doing. Folks may know that he's actually the co-chair for the current obesity guidelines, which is, of course, really actually influential because of all the major changes actually that's taking place in terms of understanding of this challenge, but also the solutions that we may have. And we are very delighted that, because I work with Sheldon Toba on the Sea Change guidelines, and, the obesity guidelines are so much important, sort of innovative component of the new guidelines that's coming out actually in CMAJ in October, coincident with the Canadian Cardiovascular Congress. And Dr. Wharton is an adjunct professor at McMaster University in Hamilton, also York University in Toronto, and he's on the academic staff at the Women's College Hospital in downtown Toronto, also on clinical staff at Hamilton Health Sciences Center. And his major area of focus is on obesity, bariatric medicine, and type 2 diabetes, which of course, so totally interlinked. And some of the other aspect, which I think is super important and something I would like to explore with Dr. Wharton as well, is involved in activism in terms of achieving health equity in Canada. He actually originally founded the Black Medical Student Association at University of Toronto. And, so this is a really something very, very important that we appreciate very much and look forward to his advice and guidance as we, expand our EDI programs, throughout our research and clinical enterprise. And the obesity is very much a major activity here. Dr. Ruth McPherson, Bob Dent, very successful obesity clinic. And so it's really a great, honor for us to have Dr. Wharton here today, and to really give us the latest in terms of obesity. And the title is actually Advances in Obesity Medicine, emphasis particularly on the cardiovascular health aspect. Sean, look forward to your presentation.
Thank you very much, Peter, and thank you everyone for having me here. The hybrid format is fun. As Peter said, I was in Ottawa back. Most of you weren't around during that time. In 1992, I did my pharmacy residency here. Lived in Sandy Hill. Really loved it. Here are my disclosures, and we'll forward the screen here with that. There we go. My disclosures are here. And the topic is going to be discussing the changing landscape of obesity medicine, focusing on cardiovascular health. So here are my two babies. So August of 2020, the Canadian obesity guidelines came out in the CMAJ. We've been working on that for 3 years. It was a big deal. And then September 2020, my other baby came around. James arrived, and this is my wife, who is a family doctor in Toronto also. So I have no good reason for putting this slide up, but I just wanted to put this slide up. So obesity is a pandemic. It affects about 13% of the globe. That's 650 million people. Canadians are about 26% of Canadians in the States. It's 40%. So we know it is a big problem. So there isn't a single chronic medical disease that is more prevalent than obesity is. And so obesity is responsible for almost 90% of people with type 2 diabetes, 90%. This is data from the UK in 2021, 77% of sleep apnea, 85% of fatty liver. And look, heart failure, 75 to 85% of people living with heart failure also have obesity. Is it causative? Is it the main thing causing it? Are they both two chronic medical diseases that are just having a interaction? So we know that there is a lot of inflammatory aspects, hypertension, insulin resistance, impairment of cardiac muscle, arterial muscle, all coming in line with it. So even if we look at things like the cardiac dysfunction that happened during COVID, also we may want to think about the fact that HFpEF may have been one of the more important aspects there. So obesity and HFpEF are tightly connected. And how do we fix that? So if we're going to fix any of these conditions, we need weight loss in people living with obesity, not living with elevated weight, but living with the medical complication of adipose tissue that's causing toxic aspects. So how much weight loss do we need? Well, we used to think it was a small amount of weight loss. We found out it's a lot of weight loss. Let's look at diabetes. So for prevention of diabetes, 3% weight loss is positive. Your blood sugar starts to go down. I mean, you could eat better broccoli tonight and your blood sugars will end up going down. So we know that we always use diabetes and blood sugar as our marker, when in fact it was the easiest thing to actually change, but it changed back frequently, right? You lose 3%, you gain 4%, you just lose all of that, whatever you had previously done. So more is better because it gives you buffer. So you can see that going up to 10%, the arrows here make a difference. So for remission of type 2 diabetes, 15% is actually needed. Every one of these things has arrows. So we no longer talk about 5%. We talk about 10, 15, 20%. We need the buffer, and we also need to get to those conditions that didn't have an impact at the smaller percentage. So how well are we doing? Well, at our clinic, every patient that walks in the door is a trial patient, or we take or is a research patient. We take their data, we ask them, can we use your data? Can we take it? And so we published this where we looked at 7,000 patients doing over 7.5 years, just doing lifestyle, diet and exercise, no medications, not having surgery. We want to see how much weight loss could they lose and what was the impact, what were the patterns. We put it into a fancy computer program. We came out with these 7 patterns. The most important patterns on this here, we're going to focus on the purple and the yellow. Minimal amounts of weight loss and stable weight loss. They made up 2/3 of my patients. So at an academic center where we have a multidisciplinary team, we're just doing diet and exercise, but they're coming in regularly. Best we could do, 2.3%. Between 2 to 3% is the best you can do in an academic center, free care, people coming often. Okay, there's a small percentage of people, 2% of people that were able to lose 21% of the weight, but obviously we'd like to get most of those 2/3 to lose as much as that group there. Question is, how do we do that? So this is from a different data set. It's even older, but it took 13 studies where they're actually, giving patients in the placebo arm as much as possible. So about the first 6 months, you lose significant amount of weight. You'd like it to stay stable, but over the next 4.5 years, you end up regaining the weight again in all these studies. So 3%, 2 to 3% is going to be the placebo arm of every study that we are going to look at. That's how you know it's a good study. If the placebo arm is 6%, then that's weird. That doesn't make sense. It's only 2 to 3%. So anything greater than that is a big deal. So today is a better day. We failed in the past horribly on a regular basis, and I think 2 to 3% is a failure over the longer term because we haven't had a significant impact on the complications. So how did we get better? We got better by understanding the actual science. And the science wasn't something that, the area of science wasn't something that I initially thought I would be in. As the internal medicine guy, I was hypertension, I was taking a look at renal disease and cardiac disease. This is neuroscience, which was the area that most of us did poorly in. And so we know that there was greater than 140 genetic regions within the brain. Genetics and neuroscience is what obesity is. So we talk about the complications. We talk about the diabetes and the heart disease and the kidney failure, but the disease is a neuroscience brain problem. So so let's talk a little bit about that. So taking a look at the brain, there's three main areas of the brain that are involved in this: the hypothalamus, the mesolimbic system, and the frontal lobe. The hypothalamus is the easiest one to have a understanding of. The hypothalamus controls automatic function, our blinking, our heart rate, and here we see then it also controls our weight. Automatic function again, and easy enough for us to see. So these are the neurochemicals that are involved there most of the time. Ghrelin is the bad guy. So if ghrelin's a bad guy, then you would block it. So we should come up with a ghrelin blocker, working on it. All those other guys are good guys. Come up with analogs that are similar to them to boost the good aspect of it. Not very fancy, but very clear. And this is physiologic hunger, meaning your blood sugar drops a little bit. The brain and the hypothalamus doesn't care about how much stored energy you have. It only cares about the fact that your blood sugar's dropped a little bit. It gives you hunger, and these neurochemicals trigger. Okay, so if we could disrupt these, then things will be positive. Now, let's talk a little bit about, so one of the major hormones there is leptin. Leptin was one of the first big hormones for us to start to understand how that hypothalamus works and how hunger works. What year do you think leptin was discovered? Okay, and I'm because we can't answer easily, I'm going to tell you what year. 1994. Like, who would have, like, it doesn't feel like, so this is a new field. And so insulin was discovered in 1921. This was discovered in 1994 by a Canadian. By the way, he was in the States. He was at Harvard when he did it. But this was the beginning of our understanding of PYY and GLP-1. I mean, we didn't hear about incretins in medical schools. Some of the younger people here may have heard of incretins, but the majority of us didn't. And we heard about, insulin and glucagon and beta cells, alpha, but not the incretins. But now incretins has been around for a while. We get it. We understand it. Leptin, but it's still a short while. And leptin is a short while. And so, so let's talk about leptin. Leptin is a hormone that tries to keep you thin. It comes from the fat cells. It says there's too much energy within the fat cells. It goes to the brain and it says decrease eating. So do people living with obesity have a little bit of leptin or too much leptin? And the answer to that would be most people would think that, well, it's a good guy. People living with obesity have too much weight. They don't have enough leptin. The answer is they have a ton of leptin, actually, because it comes from the fat cells. So what's the problem? The problem here is obvious, that they have leptin insensitivity. Just like people with type 2 diabetes have insulin insensitivity. They have a ton of insulin, but it's not working. Here again, they have a ton of leptin, but it's not working. Why isn't the leptin working? We don't know.